And welcome to our novel 4-month regimen for drug-susceptible TB webcast, broadcast live from Heartland National TB Center in San Antonio, Texas. A few important reminders before we get started. For Q&A, questions will be answered at the end of the webcast. Please use the Q&A pod for questions. Participants will receive an email at the end of the webcast, which will include a post-test and evaluation link. To receive CEs and certificate of attendance for this webcast, please be sure to have completed the pre-test, which is due today, April 24, 2025. And as far as group sign-in sheets, post-test, and evaluations, these are all due no later than tomorrow, Friday, April 25, 2025, by 5 p.m. Central Time. This webcast will be recorded and archived. The archived recording will be available on the Heartland website a week from today. Disclosure to learners, novel 4-month regimen for drug-susceptible TB webinar, April 24, 2025. Successful completion of this continuing education activity includes attending 100% of activity. Successful completion of a post-test. Attendee must score 75% or higher. Completion and submission of participant evaluation. Continuing education. Continuing medical education and nursing continuing professional development will be provided for this webcast. Commercial support and disclosure of conflict of interest. This event received no commercial support. The speakers and planning committee for this event have disclosed no financial interests. Non-endorsement statement and off-label use. Accredited status does not imply endorsement of any commercial products or services by the Texas Department of State Health Services, Texas Medical Association, or American Nurse Credentialing Center. The speakers did not disclose the use of products for a purpose other than what it had been approved for by the Food and Drug Administration. And as we prepare to begin our webcast, feel free to speak with or contact your lead educator if you have any questions or concerns. We are all looking forward to providing you with this educational opportunity and many more to come. Hello, everyone. Good afternoon, and welcome once again to our webcast, Novel 4-Month Regimen for Drug-Susceptible TB, broadcast live from Heartland National TB Center in San Antonio, Texas. So as mentioned earlier, for any questions, please use the Q&A pod. We will be monitoring the Q&A pod and the chat box as well for any questions, which will be taken at the end of the webcast. So I will introduce our speaker for today, Dr. Lisa Armitage. Dr. Armitage is a professor of infectious diseases, internal medicine, and pediatrics at the University of Texas at Tyler Health Science Center. She serves as co-medical director of Heartland National TB Center and is currently medical director of the San Antonio, Texas TB Clinic. In these capacities, she lectures nationally and internationally on tuberculosis and cares for both adult and pediatric patients with tuberculosis at a large metropolitan clinic. Dr. Armitage is the 2024 recipient of the NTCA William Steed TB Clinician Award. Please welcome Dr. Lisa Armitage.
Let's see, let me share my screen and then let's get the party started. Okay, you see my screen okay?
Yes.
All right. Hi, everybody. Sorry for the initial glitch. Today we're going to talk about the novel 4-month regimen for drug-susceptible TB, also known as Study 31, also known as the rifapentine MOXIE study. So we're going to do a little bit deeper dive into it today. So I'm sure the first question you have is, why are we looking at this? And I have a couple reasons for you, but I want to talk to you a little bit about how we got there. So a little history on the treatment shortening regimen. So when we got to a point in the 1980s, and yes, I said that correctly. So some of y'all are thinking high school, middle school, I wasn't born yet. But in the 1980s, that is when we came up with the right regimen. That is the 6-month regimen, the British medical, um, uh, it was the BRC, the British Medical Council, came up with a regimen for for 6 months. It had prior to that been 18 months and then 12 months. Now we're down to 6 months. And we have a regimen that we sat with prior the next 20 going on 30 years. And so somebody got brave and decided that they were going to try to look at shortening. So there was a series of studies, all came out in the New England Journal in 2014. I'll just tell you ahead of time, they all failed. But, talking a little bit about them, each one we learned something. So the first study was the Oflatub study. It was a all of these are non-inferiority studies. At no point has any shortening study decided that it was going to look at something that was superior. So it was a non-inferiority study. It was randomized, open label, and it was a control trial. 1,836 patients, all adults, 5 sub-Saharan African countries. They had 27% women. And what it was basically 2 months of isoniazid, rifampin, and PZA. And they took the weakest link, ethambutol, out and replaced it with gadifloxacin. So it's the first time we're putting in a fluoroquinolone. So they put in a fluoroquinolone that was stronger than the weakest drug in the regimen. And they tried just doing that with all 4 drugs for 2 months. And then they cut out the PZA and they added in and at the end did a continuation with INH rifampin and left the fluoroquinolone in. So this was a total of 4 months, 2 months of 4 drugs, 2 months of the 3 drugs, and they stopped. And unfortunately, that did not work. So when you looked at unfavorable outcomes, there was a higher group, a higher amount in the experimental group and the treatment shortening group here, but the biggest driver was the recurrence of TB. So after the end of treatment, recurrence of TB was twice as high. I still think 7% was a little high just for, standard right, but it went up to 14% and over 14% in the trial group. So that failed. So let's go to the next study. We did the Remox TB. In this one, they did 2 arms. One, they replaced ethambutol with a little stronger fluoroquinolone. This is moxifloxacin. And then one, they replaced isoniazid with moxifloxacin to see how that will work. So again, randomized, double blind, and as this one's double blind, so you don't know which one you're getting. 1,931 patients, all over 18 years. Here's the countries that were doing it, replacing moxifloxacin with INH or ethambutol. And again, they kept all, 4 drugs for the whole 4 months. So the initial phase and the continuation phase were the same, but there was a kind of a control group that they added just 2 more months of a placebo. And it looked actually, pretty good. The time to conversion of the sputum, all looked good. But then, when we got down to, again, relapse after culture negative status, that was about 2% in the control group. And I scooted my arrows over. Sorry about that. This is the isoniazid group is at 9% versus 2%, and then at 12% versus 2%. So the modified intent to treat, even when you looked at just the people who were appropriately treated, again, 2% relapse in the control group, and then you have now 8% and 12% in the isoniazid and ethambutol group. So again, not looking good. So let's move on to the next study. These all came out in 2014. They're all in I think they were all in the same New England Journal, the same issue that came out that month. Randomized controlled trial, 800 is a little bit smaller this time, only 800 patients this time. And what they did was they looked at moxifloxacin in place of isoniazid. We're going back to that But this time in the continuation phase, we did either Moxie plus 900 of rifapentine. This time they figured out that rifapentine, actually the long-acting rifamycin in place of rifampin, was going to show some benefit. So they'd already figured that out. So they gave 900 of rifapentine with a dose of Moxie twice weekly and treated for 4 months. Or they gave Moxie and 1,200 milligrams. With that 1,200 milligrams, we just learned, for a total of 6 months. And again, relapse was a problem, but interestingly, when you expand it to 6 months with the once weekly Moxie and rifapentine, that actually looked very similar to the control regimen, but I doing a little bit of digging. I think that eventually the relapse rates went up higher. The 4-month regimen failed horribly, really very high culture confirmed relapse in these patients. So those are all the progenitors to where we are now. So what do we learn? Moxifloxacin does add some benefit in replacing weaker drugs. And we did learn that, having a longer acting rifamycin actually did let you do some shortening. So that brings us to our current study. So this is the 4-month study. And, I want to talk to you about the study itself, but we're looking at, what we would do if we were going to treat with this regimen. I want to kind of get you a little bit more comfortable with what was studied, what we know, and what we don't know. So here's what we know. 2,234 participants, about 10% of them were persons living with HIV. But instead of cherry picking, a bunch of patients that had minimal disease, 1,700 of the 2,200 had a cavity on chest X-ray, had at least one cavity. They were randomized 1:1:1 to 3 different arms. And again, this is a non-inferiority study. So here are our arms. This is what we used to. The standard 6-month regimen. You get 2 months with INH, rifampin, ethambutol, and pyrazinamide. So I switched. You notice this is not RIPE. This is the standard regimens, the standard designations that they use worldwide. So we're all on the same page with what the findings are. And you get another 2 months of just INH. Another 4 months of just INH and rifampin. So that's our standard regimen that we all grew up with and we're used to. The first thing they did was they tried just replacing rifampin with rifapentine and then lopping off those last 2 months. So you had the standard 2 months of INH, rifapentine in place of rifampin, the ethambutol and PZA, dose for weight as usual. And then your continuation phase was just isoniazid and rifapentine. And that, I will tell you, cut to the chase on that, was inferior to the 6-month regimen. So the third arm is isoniazid, rifapentine replacing rifampin, and then moxifloxacin replacing ethambutol. And you get all those 3 drugs for the entire 4 months with 2 months of PZA added on. So some important things already to talk about. The HRZE, that was dosed at the standard doses, so it wasn't anything magical about that. All of the regimens were dosed 7 days a week. They were observed 5 days a week, but mechanisms were put in place to try to ensure that the patients were taking the meds on the 2 unobserved days. So that gets to be important. If you have a patient who is not able to be adherent and to be able to take the doses 7 days a week, already you're running into problems. The rifapentine was dosed at 1,200 milligrams. That was the dose. It did not go up or down for size. So, our teeny little patients who we might go down to 450 of rifampin or give the standard dose, or even go a little higher. Everybody got 1,200 milligrams of rifapentine. And the moxifloxacin dose was 400 milligrams. Now, outcomes. So this is why we have failure. There is a 2-page explanation if you would like the supplemental data where they explain for 2 pages why they felt the 6.6% margin of error was appropriate. I will be happy to send that to you. It's a lot of kind of statistical things. They compared to other studies that had been done, but they felt like they there was a little bit of grace, 6.6%, we'll say worse. Now, specifically, they said this does not mean that the regimen that touches that line is 6.6% worse. Does not mean that necessarily, but it does give, in a statistical sense, they felt like that was a buffer area that you could be maybe less better than the control, but still be considered non-inferior. So that's the best way I can explain it to you. But when you look at where they replace rifapentine, replace rifampin with just rifapentine and change nothing else. You saw it down in the per protocol patients who were treated according to the protocol and follow through with everything. They did not do as well. They did not fit inside of the margin of error of 6.6. But when you replace rifampin with rifapentine, high dose rifapentine, I might note, and added moxifloxacin in place of the weaker drug ethambutol, then you did fit comfortably within that 6.6% error. So this has led them to call this a non-inferior regimen. Completion, just some housekeeping things. In order to be considered complete, the completion is just like our standard 6-month regimen. It is based on the total number of doses taken. So for the intensive phase, you have to have 56 doses, that's 8 weeks, and you have to complete those within 70 days. If you look at that, that's very similar to what we do now, as you cannot have more than a 14-day interruption in the first 2 months. You have to get all of the doses in within 70 days. If you miss 14 doses in that period, then you have to restart. The continuation phase is only 63 doses. That is 9 weeks. And these 63 doses have to be completed within 84 days. And total number of doses, 119 doses, taken, that's 17 weeks. And it must be completed within 22 weeks. So you have 5 weeks, a little bit of grace, and that is about it. Yeah, 5 weeks, excuse me. That sounded weird. So you have 22 weeks to get the whole 17 weeks in, and yes, you can miss, a total of 5 weeks max for the through the entirety of the treatment. So some points to consider. I told you I was going to come back to why are we talking about this. Patients want shorter regimens, but patients also want regimens that are safe and effective. We need to consider what the needs of the person who is suffering with TB is. Having somebody visit them every day and give them their meds, having them, I always tell my patients, TB has taken up enough of your life. We want this gone, and we want it to go for forever if we can, but for as long as we can, work to get you a cure. So, in Texas, we're starting to kind of look at some things and decide that, okay, do we have a new tool? We have something that is available, and we need to be thinking about how we can effectively, treat the patients that would benefit from it. So also one thing to consider, look at the smear conversion by 8 weeks. So individuals that converted, within the first 8 weeks, which is our measure of, infectiousness, maybe not so much so with the new guidelines, but also, saying that we're decreasing the burden of disease on that patient. Within the first 8 weeks, you had 63% of patients on the standard regimen were converted, but in the rifapentine moxi arm, almost 80% of patients had converted by 8 weeks. So this is a benefit to the patient. This is a benefit to their environment, the people in their house that are close contacts to them. This is benefit all the way around. So there is some good things about the study that we need to consider. The one thing that I want to keep hammering home to you, I want you to think about this. The study compared 4 months of rifapentine moxi regimen to 6 months of standard therapy. There's no way you're going to treat CNS disease in 6 months. There is no way that you're going to treat miliary TB in 6 months. There is no way that you're going to treat, a patient who has who can't tolerate certain meds, in 6 months. So you have to, look at the fact that what the comparator was 6 months of standard therapy, not 9 months, not 12 months, not, other extended reasons for extended treatment. So quickly, what does the CDC says? The CDC recommends the 4-month rifapentine moxie regimen for treating patients that are aged greater than or equal to 12 years of age. So it has not been studied in children under 12, but that study is underway. So we feel like, if you get short regimens, you have the SHINE regimen for children who are under 12 right now, who are 17 and under. So any child, you have a shortened regimen if a child has minimal disease. But if you have a child who's a little bit older and has a cavity, or, a little bit more, or they actually have disease where you're able to obtain a culture, those children are still stuck with the longer treatment. So we're trying to be more inclusive of everybody. The patient must have a body weight of greater than or equal to 40 kilos. So that's 88 pounds. You have to weigh at least 88 pounds to qualify to take this, to do this study. And because some of the drugs are standard, most notably the 1200 of rifapentine does not change. If you're Dr. Seaward's side, if you're my size, if you're if you're Shaquille O'Neal size, everybody's getting the same dose of rifapentine. So the weight cutoff is 40 kilos. It said with pulmonary TB. The CDC is still not saying, recommending that you use this for patients with extrapulmonary disease. It has to be caused by organisms that are not known or suspected to be drug resistant, and you have to have no contraindications to this regimen. And we're going to talk about what contraindications might be. Monitoring first, the regimen has isoniazid. So, this is our same isoniazid toxicity. Things that we screen for don't change just because you have this regimen. Still looking for transaminitis, still looking for peripheral neuropathy, CNS symptoms, any of this is just popped out of my slides on the TB drugs, hypersensitivity reactions, rash, all of the things that you look for isoniazid in the standard 6-month regimen, still look for it in this regimen. Rifapentine is basically a long-acting rifamycin, highly protein bound. That's why it's able to stay in the system for so long. So it stays in, it has a longer half-life than rifampin, but the adverse effects are very similar to rifampin. And resistance is noted through the RPOB mutations, just like rifampin. So some things to note: the half-life of rifampin is about 2 hours. Rifapentine is 15 hours. That allows us to have the drug hang out a lot longer and give the opportunity to work for a lot longer with each of the doses. There's no food requirement for rifampin, actually absorbed a little bit better if you don't eat, but rifapentine has the absorption can go from like 34% up to like 84% increase if you have it with a meal. And if you have it with a meal that has some fat in it, that's even better. So note, that's one thing that's a little bit different about using this regimen now, is you do want to have the patient eat something, and if it has a little fat in it, that increases your absorption. Cavitary penetration with rifampin is good. I think good is fair. That's kind of like a 3 out of 5, but it is poor for rifapentine. Hence why the doses need to be so high, and the fact that it is long acting helps overcome some of that. The rifampin and, therefore rifapentine toxicities you want to look for, generally well-tolerated med. Only about 1.9% have to switch from rifampin. Rifapentine is probably pretty similar. The number of pills is a bigger deal than the actual toxicity from the med itself. Still get orange discoloration of body fluids, even though it's rifapentine. Drug interactions is the biggest thing. If you have induction of the hepatic microsomal enzymes, the cytochrome P450 complex, that does not go away. And you have high doses of a rifamycin that is coming after every drug that you have that has a major interaction. Again, cutaneous reactions, about 6%, usually self-limiting, pruritus or itching and flushing, usually 2 to 3 hours after the dose. Again, if a lot of times just having the patient well hydrated, and sometimes you may need to pre-medicate with like Zyrtec or Claritin or something like that, something non-sleepy at the preference of the patient. If the patient wants to take their meds at night, Benadryl will help them cut off any reaction they may be having to the med, and at the same time get a decent night's sleep. PZA, none's changed. Hepatotoxicity, GI symptoms, asymptomatic hyperuricemia, still going to see that, and then gout exacerbations in patients with pre-existing gout. Again, rash, dermatitis, nothing new here. This is the same things that you're screening for now with the 6-month regimen. You still have to screen with the 4-month regimen. Fluoroquinolone toxicity. So this is the new player in the regimen. This is the new one that we have to consider. Gastrointestinal disturbance. It says nausea and bloating in 0.5 to 2% of patients. I personally have more of a problem with levofloxacin with that than I have with moxifloxacin. So given that moxi is is the drug that's in the regimen, I think that the GI disturbances you'll find will be less of a problem. QT prolongation, on the other hand, is something that is more associated with moxifloxacin than levofloxacin. And again, the tendinopathy, the thing that we worry about, much higher risk of tendinopathy and tendon rupture with levofloxacin. There actually is a study in a British journal that showed that there was really in the 1 million patients that they pulled all of the toxicity data for, they did not find any evidence of tendinopathy with moxifloxacin. But that doesn't mean as we expand this into 3, 4, 5 million of people that eventually get into the drug, you wouldn't see a subgroup that would have a problem with the drug. So we at least owe it to the patient to look. CNS toxicity, I have seen my patients on moxifloxacin have maybe a few more headaches and some other things such as that, but that more so than levo. So just to kind of recap, I would say that GI disturbances more likely found with levofloxacin, but everybody's body is different. If the patient has nausea, you still have to take that into consideration. QT prolongation, probably more so seen with moxifloxacin. I'm not sure if I have it in my slides further along, but I will say that no, you do not need to do serial EKGs in patients who would take this regimen, unlike, for example, VPAL regimen, where you have 3 drugs, all 3, can increase the QTC. You don't have that in this regimen. You have a single drug, and unless the person has underlying problems with their cardiac rhythms, unlikely to see that cause a problem. Tendinopathies, more of a problem with levofloxacin, but CNS toxicity may be something that you would see with this regimen since it contains moxifloxacin. I want to go back to just the safety data because remember we talked about the patients want shorter regimens, but they want them to be effective. And we've shown that this is a non-inferior regimen. It is non-inferior to 6 months. And we have so the next thing, patients want things that are safe and in addition to being efficacious. And just to point out, primary safety outcomes, they looked at grade 3 or higher adverse events. And that was, maybe even just a little bit lower in the study arms. I would call this potentially, I would just call it equivalent. So 18.8 versus 19.3% of participants had some kind of toxicity. Secondary safety, maybe signals a little bit higher in the rifapentine moxi arm. Any serious events, essentially the same, but maybe a little bit less in the rifapentine moxi arm, and then less death. Less death is always good, in my opinion. For the ALT or AST, it says a little bit lower, but really high rates. I pulled this out of the study data, the supplemental data for the study, and looking at ALT, really very similar. If you're looking at the controls, this is the weeks from randomization. So this is, once you got randomized and started on the trial, there was maybe an initial little bump in the control arm, but pretty much and for the ALT, all three regimens ran pretty consistently the same. So this is, as a safety measure, that's always nice to see. Total bilirubin a little bit different. This is the change over baseline, and it just starts kind of dropping off the billy in the control arm, but you have very high dose rifamycin. So you see an increase over the upper limit of normal, not quite, it's not to one time, not even to 1 times the upper limit of normal, but you do see with that high dose rifapentine that the billy does increase. So looking at the labs for your patients, I would expect, looks like, pretty consistently that you saw a bump in the T-billy, but eventually it came back down toward normal. So this is great. So we have, some people who we look like, we feel like we might know kind of who would benefit from it, but we also want to be mindful of the folks that we don't want to apply. So I'm like, a hammer is great if you have a nail. A screwdriver is great if you have a screw. A screwdriver is not as great if you have a nail. And if you need to cut wood, neither of these tools work. So keeping in mind that, we have a whole range of patients that have tuberculosis. We want to apply the tool that we have to the ones that are going to most benefit from it. And we don't want to do any harm to the ones that, are maybe harmed or just absolutely are not going to have the benefit that we would promise them. So patients less than 12, not yet. Patients over 75 years old, why is that? We say in all of the guidelines that patients greater than or equal to 75, you need to use PZA with caution. This regimen has to have the PZA. You can't just take drugs out, and say, well, we'll just go with the ones that work or the ones that are not going to cause harm to my patient, and we'll just use those. Doesn't work like that. So you can't just be making substitutions. So the PZA has to stay. So our greater than 75-year-old patients, we really need to be careful and watch over them. Pregnant women, no studies. Pregnant women were excluded from this particular study, like a lot of other studies. And so we have no data. So we can't apply this to our pregnant ladies quite yet. Patients with severe liver disease just are not likely to tolerate isoniazid and PZA. We already know going in that with severe liver disease, they're highly unlikely to be able to tolerate those two drugs, even for the 4 months that you have to give it, especially with a high dose rifamycin. So severe liver disease, probably getting out with that. And then patients with severe renal disease. So those are the ones who have a creatinine clearance less than or equal to 30. Again, no guidance on renal dosing. So PZA has to be dosed renally. The isoniazid, rifapentine, and moxifloxacin would all be okay, but PZA would have to be dosed differently, and we really have no guidance on that yet. So patients with multiple medication interactions, I think this is going to be the one that's really going to give us a problem. Remember, rifapentine works a lot like rifampin. It works exactly like rifampin with regard to drug interactions. So if you have a patient who is on medications for hypertension and for diabetes, patients on Eliquis, seem like I have 500,000 consults of patients with Eliquis. That is the drug du jour right now. And any other medication where they really need that medicine to be effective for them, that is impacted by rifampin, then you're gonna find that those patients are going to be impacted, severely by having a high dose rifamycin. The study specifically excluded patients with CNS disease, bone disease, miliary disease, and pericardial TB. These are all areas where you do not want to have short course treatment. You want to make sure that you're treating long enough. The chances you're going to treat CNS, bone, miliary, or pericardial TB with just 6 months of therapy are pretty small. So I've not tested against 9 months of therapy. So I don't know, what the equivalent length of time is for that with this study. So not for bone, CNS, miliary, or pericardial disease. Tiny people, small human beings, less than 88 pounds, they must weigh at least 40 kilograms. So if the weight cutoff is the weight cutoff. Do not put rocks in their pockets and put them on the scale. Try to measure their weight accurately, please, and let's not do anybody any harm because we want to be done with them quickly. Patients with long QT syndrome. Again, moxifloxacin can prolong the QTC. So in those patients, you want to, probably not the best regimen to consider for them. Now, some potential challenges we want to talk about. Pill burden. The biggest thing, I think one of the things that we're going to have to, seriously talk about is pill burden. So you have one isoniazid tablet at 300. You have 8 rifapentine capsules, 8 tablets of rifapentine, 1 moxifloxacin, that's 400, and 1 pyridoxine. So that's your B6. So that right there is 11. If you're counting with me, that's 11. So for smaller patients with PZA, you would just add 2 more. That's 13. But if in patients who are getting the grown man version of that, where they have 4 PZA tablets, now that's 15. So 13 to 15 tablets is going to seem and feel like a lot. So this is a conversation now you're having with the patient. But remember, the base, everybody gets those, and your PZA, you can vary up and down both based on your weight, but it starts off at baseline, a lot of pills. So tolerability is going to be, we've already seen the safety signals look good, that we've seen the efficacy looks good, but tolerability is going to be something that we have to think about. It's a lot of pills, and it doesn't go down, that many. The PZA goes away, but you're still with 11 pills every single day. So familiarity with the regimen is something that we're just gonna have to develop on the time. Substitutions, there is no guidance on substituting a single one of those drugs. So usually if something happens with INH, we sub in, the fluoroquinolone, but the fluoroquinolone is already in there. We do not have room for substitution. If the patient has resistance, you have to pull them off this regimen. It is not going to work. If the patient has intolerance to one of the drugs, you have to pull them off the regimen. You have to switch them to something else because all of the drugs in the regimen have to be in there. Into treatment, and you feel like they need more treatment, there's not really any guidance on how long to extend treatment. So we have a 6-month regimen, and we get to the end and they still have a cavity, and it took them, like 4 of the 6 months to finally convert, and we just add 3 more months on and we feel good about ourselves. And we have no guidance with this one about how long we want to extend, if we want to extend, what we want to extend. So still a little bit more to be learned there. So part of it is getting it right in the first place. You don't want to say to a patient, okay, I want to start you on this regimen, and I know it's a lot of pills, but the good thing is you get 4 months of treatment and you're done. And then you don't. Then you get to 4 months of treatment and you're like, I'm sorry, but I don't think you're cured. I want to cure you. And, what is it that we're going to have to extend your treatment. So that kind of lost the whole, the whole benefit of getting on and taking, 11 baseline pills every single day. So drug shortages, that has been the singular reason why we have been kind of stalling and rolling this out in Texas. But we think we finally have this sorted out. I want to give a shout out. I don't know if the pharmacy people are on the call, but I will tell, everybody who's on here that the state of Texas pharmacy folks working with Elizabeth Boy up in the, at central office are always looking out for keeping our drug supply stout. So the duck feet are going all the time, trying to make sure that we have all of the drugs that we need for our patients. And they've gotten us to a point where after a shortage of rifampin and then rifabutin and then isoniazid, I want to start with the first shortage. When this regimen first came out, the reason we didn't jump on it really quickly was rifapentine was in shortage for the entire country. And so the question was, would you rather treat one patient with this regimen, or would you rather treat 8 patients with 3-HP? So when you get down to that, the 8 versus 1, this regimen kind of got backburnered here for us in Texas. But now, nationwide, the rifapentines opened up a little bit, not for everybody. For those of you who are still struggling, my heart goes out to you, because nothing makes you crankier than knowing what you need and not having it. But we went through isoniazid shortage and most recently moxifloxacin, and we finally now have all drugs. So we are going to make hay while the sun is still shining and try to get some, work out something on treating patients. So in Texas, before y'all all run out and start writing for this regimen, we have a pilot. We have a pilot just, look at rolling this out in our different, areas in the state. We picked we picked providers all over, started, of course, here. I want to try it out myself. We're doing it here in our clinic, but also some out in east, west, north, and south. The folks up in Austin have picked a good, solid group of doctors, and we're going to be having a good, hard look at this and what it looks like, and trying to come back with some guidance when we roll it out fully for everybody to know, what we found and how it's going to work, all the way from the forms, the paperwork and the monitoring, to the cure and any other random, like, weird side effects that we note. So back, let's talk about the pill burden. Like I said, I want to linger on this for a minute. You got 1 isoniazid, 8 rifapentine, 1 moxie, and 1 pyridoxine. And so basically, these are the doses. Everybody gets 300 of isoniazid. You notice body weight has to be greater than 40. Just has to be greater than 40. Doesn't say if you 300, 400, 500 pounds. Does not say. Only thing you have to be is greater than 40 kilos. And you get 30 of isoniazid, 300 of isoniazid, 1,200 of rifapentine, and 400 of moxie. And then you get the standard doses that we've used, forever for pyrazinamide for your weight. This is out of the NTCA has a fact sheet, and I love this because basically they break down for you how many pills you're going to be taking. So this is, a person that weighs over 75 kilos. So you have the 4 PZA capsule tablets, and you have the 4 EMB tablets. You have isoniazid, rifampin, and a B6, right? So during the continuation phase, you're down to just these 4 tablets. And that is probably, what your patients are like. My patients, very happy time to be down to 4. Well, with the short course regimen, so good news is you finished 2 months earlier, but you still have 11 tablets that you are taking during the continuation phase. So in this place, you would go from 15 down to 11. But 11 versus 5 may or may not be trivial for the patient. This is where you have to have some conversations. So the what ifs, it's always the what ifs. So what if the patient was started on RIPE? Can you switch to the short course regimen? So my first question, if the patient has been on RIPE for an extended period of time, getting toward, they've been in the hospital 4 weeks, 6 weeks, you're starting, at that point, are you really going to be shortening that much? If the patient has been tolerating the regimen, do you really want to switch? And the next question is, does the patient want to switch? You can offer the patient this, but if they're getting toward that, I'm going to go down to 4 tablets, and now you're offering me 11. Do I want to do that for 2 months of my life back? Maybe, but that's a question that you can't, you can't speak to for someone else. Important to note, you cannot give credit for prior doses from another regimen. You need to do the entire 17 weeks of the moxie rifapentine regimen, regardless of prior treatment. So that's going to be 4 months tacked on. So just like doing the numbers game, keep that in mind. You're going to a higher number of pills and you're still having to do the entirety of the regimen. And speaking of speaking for people, I want to share something with you. We had a patient um, summit kind of at here in San Antonio and asked some of our TB patients to speak their truth. And so a young man, it was at a research facility, and a young man asked if you could have a shot, one shot once a month, or even once a week, would you rather do that than take the pills? So my first thought is I'm thinking at it from a clinician having to give a person a shot, and much as we just got done with kanamycin and caprimycin, and we're not wanting to give anybody shots ever again in life. And every single one of my patients, an 18-year-old, a 30, like mid-30s-year-old, and an 80-year-old, every single one of those patients said they would take the shot. So try not to think that you know what your patient wants, and ask your patient what they want. Next question, what if the cultures don't grow? Well, I would at that point, you just continue the full 4 months. And if the patient is responding to treatment, you're going to reevaluate at 2 months, just like you would if the patient was on a 6-month regimen. All of the evaluation parts, none of that's really going to change. One thing that's going to change is we're going to have now rifapentine and moxie in there. And so some of our toxicity screens that we're evaluating for to make sure that we're finding, any of the side effects that they have that may pop up that are not listed in the study itself. Those we're screening for, but all of the rest of your monitoring of the patient is going to be exactly the same. So if at 2 months your patient is looking great and things are proceeding well, then just continue. But if the patient is not responding treatment, at that point you want to stop therapy and reassess. That's what we do every time. The patient might be on the standard 6-month regimen and not responding. That's when you're looking for things that might be impacted. So I pulled this from Dr. Seaworth's talk on World TB Day. Lessons from drug-susceptible phase 3 trials. And if you remember the 3 that I showed you that failed, those are these 3 down here. And what they learned was when they separated patients into easy to treat versus hard to treat. So who's hard to treat? Patients with, like comorbid conditions, patients who are struggling to stay adherent, patients, who are on medications that are interacting, extensive disease, CNS disease, like multiple cavities, almost all of their lungs taken over by TB on both sides. Patients that are hard to treat. When you saw where the failure was, that was really in that group of patients. So we're going to have to consider that one good regimen is only good for the subset of people that can benefit from it. So we're going to have to be looking at, kind of our easy to treat patients, but if the 4-month regimen is here. And so it actually, at the 92, say you want 92% of patients, to do well, it falls just a little, short of that. So probably closer to 88, but, on the time since starting treatment, it does really, really well. And then, we see that it's the control fails to hit that mark, but this regimen is not that far behind it. So again, really solid regimen, but is going to work best for the patients that it's going to work best for. So when the first time I talked about this regimen, I went to the last, I have 8 patients. The last 8 patients that I had, no, 6, actually, it was just 6 of my patients. And I just pulled the last 6 patients that I had before I gave this talk. And I think April of last year. And I looked at whether or not in my population I would use this regimen. And I think I looked originally at like 10 patients, but some of them were kind of more complicated to be adding into the talk. But Janice Louie actually published a paper on her experience, and I think she had 130 patients, and 60 of them qualified for the study. She has a lot of more elderly patients in her population. And so I think that was part of it. But really, in looking at my own patients, the first patient, here, 26-year-old US born, otherwise healthy, had a pretty extensive cavitary disease in his right upper lobe, and he would have been great. This guy would have been, he was a workout guy. He took his meds. We put him on VDOT and he was fabulous. And then he came back INH resistant. So that, like, he would have failed. He would have been a fail, and I would have had to switch him to a more standard regimen. Um, this, my little patient over here, 32-year-old, also US born, but has current heroin use. I will kick her absolutely into remission. She actually got out of actively using, and went to a methadone clinic and is doing really well with that. But there is no way I'm going to have a high dose rifamycin, very similar to rifampin, and be able to prevent kicking her into withdrawal. Next patient, a 66-year-old man from Mexico, poorly controlled diabetes. Just an aside, one of the authors of the paper, Dr. Kurbatova, Katarina actually sent me a poster. Diabetic patients tend to do relatively well with, I'm waiting for them to kind of separate out, the efficacy, but safety-wise, diabetics actually did okay. This was not any more toxic to diabetic patients than it was to non-diabetic patients. So I would not hesitate to try with a diabetic patient, but this is a lot of disease, a lot of cavitary disease in 3 lobes of his lung. I did not think I would cure this guy in 6 weeks. So I would have thought carefully about treating this patient. Now, 18-year-old US born, otherwise healthy. She was perfect. I would have definitely used that regimen on this child, but she was in the hospital for 6 weeks before we even got her. So I would have to sit down and talk to her about pill burden and about the number of pills that she would have to take, and whether the shortening of the regimen would be something that she'd be interested in. Here's a 56-year-old man from Mexico. Looking at his imaging, just pleural disease would have been great. He had end-stage liver disease, so that got knocked off. There's a patient, 64 years old, recent immigrant from Venezuela, who was a little nervous but otherwise healthy, that ended up with MDR. So again, it's some, we're every patient, we're not going to hit every patient with these regimen. We have another, kind of arrow in the quiver. We have another tool in our toolbox. We have something else that we can offer patients who want shorter treatment, who are willing to take all of the meds. But I would say, as we roll out newer, better, we have to remember, as Dr. Seaworth points out all the time, one size does not fit all. We have to be considerate of our patients and decide, what we have to offer them that is going to give them something, a little bit better. And then we have to go with that. And so I deliberately try to cut it a little bit shorter so that we have time to address questions. One thing I didn't emphasize as much as I wanted to in the talk is the 7-day-a-week dosing. So I gave you what the requirements were for, what you had to do, how many doses you have to take, what the timeline you have to take it in. But really, this is a 7-day-a-week regimen. If and when the SDOs come out and we talk about what you have to do to be able to take this, my first thought is VDOT. It's good to have the patients on where you're observing them for a week or two to make sure that they're not having any toxicities or lying to you about having toxicity. But if you can have those weekend doses observed, that is optimal. If you can't, you have to have some really firm conversations with the patient about them taking the meds every single day, helping them understand that they don't work as effectively if this regimen is built on them being able to take those weekend meds. The way you get it shorter is you take the meds 7 days a week. That works with the standard regimen as well, but we just gotten used to extending if somebody is dragging feet with responding. But you really, really need to be on top of having the patient take the meds, including on the weekends. And now I think I have some scouts that are doing the Q&As for me, looking for questions. I've been going nuts in the chat box, so let's start firing on the questions.
All right, so we have about 8 questions so far.
Okay.
So the first one from Pamela Salinas: would continuous AFib at baseline be considered as a need for a monthly EKG?
I would talk to the patient's cardiologist. If they, if they have continuous AFib, they have a cardiologist. I would be a little concerned about any of the rhythm, rhythm maladies with the moxifloxacin. But again, that's a question for the cardiologist. That's a phone call or an email to ask them, do you want to give the patient a fluoroquinolone? Does the patient have anything that is, that would preclude them being able to take that safely?
All right, next question from Beth Walsh, and it's a DC, abbreviated PZA after 40 doses.
Yes, in this regimen, you discontinue the PZA after 40 doses. It's 56 doses. Sorry, because remember, it's 7 days a week, so it's not just the 40 of the 8 weeks. It is the full 56. Counting the weekend doses. So yes, after 8 weeks, you would discontinue the PZA, which would decrease the pill burden some, but compared to the base 11, not a whole lot.
All right, next question from Ashley Hill. If you need to extend, would you keep INH and rifapentine until we meet conversion or improvement, or would you do INH and rifampin until improvement is achieved?
Okay, so in this regimen, the continuation phase has isoniazid, high-dose rifapentine, and moxie. So you're going to keep isoniazid, high-dose rifapentine, and moxie until you complete therapy. There's no dropping off. You don't drop off anything except the PZA after the first 56 doses. Everything else has to stay. So again, I keep saying that out loud. 11 pills. That's still 11 pills that you're having to leave until. Are we good? Y'all know how to find me, right? So stop sharing. Okay.
All right. So, Next question from Barbara Martinez. If patient is started on short course regimen and is discharged to a health department not participating in this study, the patient gets switched back to RIPE. Oh, hold on, there's more. Can we count the doses on the short course regimen towards completion of therapy?
No, you cannot. Right now, where it stands, this is also the CDC guidance and the guidance that's in the that's put out by NTCA, is that if you switch from one to the other, it's a restart. So that's why it helps to get it right in the first place. So no, you cannot give credit. This is like, I know y'all do that with 3HP and you try to count how many doses they had and how effective it is. It's a short course regimen. If you cannot get 4 months of this regimen into the 4 months of pills into the belly, then there's no study to say what you can do back and forth. So absolutely not. If the patient comes out of the hospital and if this happens in Texas, if the patient comes out and you can document that they have been treated appropriately, call us at Heartland and we'll see if we can't work out something to help you manage the patient. But in general, to answer that question, let's just say the patient starts taking the 4 month regimen and I don't know, has some toxicity, has to be started on a medication for something that's going to interact with the pills, whatever, then you still have to start from scratch. So again, the benefits of a short course regimen are not so beneficial if you switch and have to take the same amount of time. But going in either direction, switching from one to the other, you have to switch as a total restart.
Okay, next question from Dr. Yamba. If patient has a lot of side effects, can't tolerate this regimen, how do we account for the meds taken before switching to another regimen?
If you think that something that they were taking before was causing the side effects, stop all the meds and then restart the regimen. If they have the same side effects, then now you have to go back you have to switch back to the standard 6 month and do a drug challenge. So like there's no point in doing a drug challenge with this regimen, because if you can't get all 4 drugs on, you can't use it. So if you know one of these drugs is causing the patient intractable nausea, intractable headaches, rash, that very clearly, happens with dosing the meds. If you know that, then you have to switch back to a regimen where you can do a drug challenge, because with this one, if you can't have all 4 of the drugs, you can't use it.
All right, next question from Jenna Hext. Let's see. Recently started a patient on this regimen. They are currently inpatient at the hospital, having nausea and rarely vomiting, but becoming disgruntled from GI upset. A recommendation was made to split the dosing to help tolerability. Patient is already on Zofran.
No. Yeah, if the patient can't tolerate the regimen, you have to, you should not be splitting doses under any circumstances. Answer like TCID occasionally, will split off PZA from some of the doses, but this was when we were doing MDR treatment with things like ethionamide and cycloserine and any number of things that were causing, GI upset, that and PAS. So they were trying to split those drugs apart from each other, but this regimen has been just basically dosing all of the meds together. So if you're out there splitting doses, please stop that.
Next question from Brenda Montoya, I believe. Would any states, counties, cities that have a current protocol for this regimen be willing to share their protocol?
Texas is coming. We're in the works.
Question from Beth Waltz. What are the intervals for chest x-rays during treatment?
Baseline 2 months, and then probably at the end of therapy would be smart.
Question from Julie Lowe. Can you read QT prolongation with AFib? We need to ask a cardiologist.
Yes, please ask a cardiologist. I can do some standard EKG reading, but you do not want my EKG reading to be the thing that protects a patient. I'm not the one. I have cardiology friends for that.
Question from Tara Rhodes. If started on 4-month treatment, asymptomatic, abnormal chest x-ray, TST positive, negative sputums, no change at 2 months, do you consider LTBI treated like with standard RIPE and rule out other reasons for chest x-ray abnormality?
Yeah, I would. And based on there's a regimen, the isoniazid and rifapentine regimen that nobody liked that well, that was studied in individuals with HIV. Also, the current study 37, we don't have for sure that one works, but they're looking at rifapentine dose daily for 6 weeks. I think, I wouldn't feel any less comfortable with, high dose. So, okay, the 2 months of the 2 months of RIPE, being considered, adequate treatment for LTBI is based on a study that showed that daily rifampin and PZA actually was adequate for LTBI, but it blew up a bunch of livers and lost favorability for that. I would not have any reason to believe that daily rifapentine, high dose rifapentine, and PZA together, instead of rifampin and PZA together, I would not have any reason to believe that would not be adequate for treatment. So we'll call that, we'll call that yes. I would say yes.
Next question from Devari Mandaji. Using short courses under presumption that disease will be MTB susceptible, how is this handled if patient ends up having M. bovis?
If the person ends up having M. bovis, you have to switch over to the 9 months of standard INH rifampin, and you can do ethambutol for a month if you have, usually you leave the ethambutol in only if you have concerns, but basically you would just switch them to INH and rifampin and treat for 9 months.
And that
goes the same if they end up coming back INH resistant or moxifloxacin resistant. or PZA resistant. If they come back, obviously, if they come back rifamycin resistant, now we're going in a completely different direction. But you'd have to make the adjustment for any drug in that regimen's being resistant. You have to make the adjustment back to the standard treatment for that. So isoniazid, fluoroquinolone, rifampin, PZA, and ethambutol. That's the standard for drug treatment for INH resistance. For PZA resistance would be INH and rifampin. So basically, you have to go back to what you default to whatever the treatment is for that resistance. And another thing, I'm like figuring all the things that I forgot to say anything about is if your lab that you use does not test for fluoroquinolones, then you should not put patients on the regimen. You do not know conclusively that they are susceptible to the fluoroquinolones. This is not a regimen that you can use. The state lab does all of them, and I know I will tell you a little trick that I learned from Ernest Martinez down in Houston when we have one of our hospitals here in San Antonio that sends their specimens out or do their specimens in-house, and I have trust issues. Whenever our CI goes over to visit that patient, they go and they smuggle in a sputum collection tube, get the patient up, put their feet on the floor, teach them how to huck up a nice juicy loogie, and we smuggle our specimen back out and send it to the state lab from our clinic. If you do not have access, you want to use this regimen, your patient is especially if they're smear positive, get in there, get your tube in there and get a specimen out and get it to our state lab so that at least you have some information, that you can use to use the regimen. But if you know going in ahead of time, you are not going to have fluoroquinolone susceptibilities, you cannot use this regimen. You have to know that the patient is susceptible.
All right. Question from Annette Martinez. The NTCA provider guide states that chest X-ray at 2 months and end of treatment is optional. Is there a reason for that?
I mean, like nationwide, people don't always do things like we do them here in Texas. Our SDOs say that we need to do it, and it's the 2-month point is the point at which you decide if you need to extend treatment, if the patient is responding. This is your review, your 3 legs of the stool. Microbiologically, have they converted their smears or cultures, or are they still, struggling? Clinically, have all of the symptoms that they had with TB resolved? Night sweats, fevers, how they gaining weight? Clinically, do they feel well? Is their energy back? And then the third one is radiographically. Are they improving radiographically? Are you seeing improvements in decreasing in the size of cavities, less infiltrates? Is the patient responding? So I don't see how you can, if you're going to give a provider guide that's out, for use in general, you have to take into an account that some people don't have the budget or the access to be able to do those type of things. So if you make it mandatory, then people who don't have those feel like they can't use this. If they've worked it out to where they're not evaluating their patient at 2 months and they're still able to tell, and have good outcomes, who are we to judge? But here in Texas, we're going to get our chest X-rays at 2 months and the end of treatment.
Last question from Beth Waltz. What are the psychiatric disturbances you see most with Moxie, and are they reversible generally?
Yeah, generally, this is the only drug that I really have concern with irreversible side effects is linezolid. That one tends to have some peripheral neuropathy that may not respond to stopping the drug. Every one of the drugs in this regimen, if you stop the medication, then the toxicity should stop. So that's first. Moxifloxacin, I've seen patients more so with headaches, but what they've described is also, just kind of if patients who have a low seizure threshold, who are on medications for seizures, may lower their seizure threshold, or where they are requiring more of the meds. If a low dose of an anti-seizure med is actually keeping them from having seizures, they may have to go to a more standard dose if they're on moxifloxacin, but isoniazid can do that as well. Mostly what I've seen personally is patients complaining of headaches. are just kind of feeling like, heavy-headed, is how one patient described it.
All right, and that was the last question. Unless anybody, we still have a few minutes, unless anybody has other questions for Dr. Armitage. Oh, Barbara, hold on, Barbara, I'm sorry, give me a second. Can you?
Don't ask me anything hard, Barbara Martinez.
Oh, Barbara, you should be able to unmute yourself so you can ask the question.
I do. So the question about the bovis, Dr. Armitage, we said that you had said that we would have to switch regimens, right? So if we're treating the bovis, I don't know, the patient's 4 weeks into the regimen, and then all of a sudden we get that PCA resistance. None of those prior doses would count, right? So the nurse case manager would have to start the count over.
Yes.
Is that what
as written, that is how, as written, yes. Okay. Would I be looking at things from a patient? Because I have isoniazid and high dose rifamycin. I'm thinking that's great, right? And so those are the two drugs that I would be using for in bovis. So there's nowhere is that written, but we do a lot of things that are not written down, but we watch over our patients. But when I get to 9 months,
that would require a consult.
Yeah, if I took I'd look at a hard look at that patient. If they've been taking that medicine 7 days a week and they have isoniazid and high dose rifapentine, I would be leaning toward maybe considering some credit for that. But I would have to see all of the information. What you don't want to do is short a patient and have them relapse. Like this is a huge burden on their life, having to take the pills every day, and the worst thing you can do is get down to 6, 7 months of treatment, have them stop and have them have to start over from the beginning. We always want to be mindful for the patients that we don't do that. But that's a good question, because if 2 of the drugs are the 2 drugs that you need, and they've taken it for a whole month before you get the susceptibilities back, I think I'd be following the course of that patient. And if they responded completely after 9 months, including those, I might consider that. But let's talk about it first so that we don't short your patient and have them have an undue burden on their life.
As Dr. Seaworth used to say, get it right the first time or they'll be back.
Yes, that was her line.
They always come back.
They always come back. Get it right the first time.
Yeah, let's see. I think Debbie has a question. Am I understanding correctly? You cannot extend treatment with this regimen.
Doesn't say that you cannot. Like if you get to end of 4 months, there's no guidance on that. That's a question. That's a question that we might have to be answering with you. There's zero guidance on that. Like I said, I would not, if I had a patient that I knew had, the big no-nos, CNS, bone, and miliary disease, I would not be. If there's extensive amount of disease in the lungs, I want to treat that patient long enough to get them cured. And if I just look at that and I'm thinking I wouldn't treat that in 6 months, then I wouldn't start something to treat in 4. But if you feel like you're good, remember the patient I had that just had the right upper lobe cavities and a little bit of infiltrate on the left side. That guy, I thought he would have done well. He was 26, he's young, he's healthy. The only gripe he had was that he could only play 3 rounds of basketball and not 6 rounds of basketball. And I'm like, yeah, okay. I'm out there for about 5 minutes and I'm sucking wind. But this guy I thought would have been perfect. If he wasn't INH resistant, he probably would have been perfect. But what if I got to the end of 4 months and that cavity hasn't closed? What if it took him 2 months or, 2.5 months, to actually finally convert? I'm not sure I would stop at 4. At that point, I would probably extend treatment. But, again, we'd have to look at what your patient has. Did we do 1 month, 2 months, 3 months? If we're extending again, we've gotten past the benefit of the regimen and gotten into another, kind of realm of time. But I don't know, if we had to extend 2 more months, then he got to 6 months, maybe treat in 6 months instead of like the 9 months it would have taken to close that hole with the other regimen. Maybe that's a win. We don't know. But there is nothing discussed about that. They wanted to stop the treatment. When they stop the treatment and see what the patients did. They wanted to do a 4-month, not a 4-month, with a bonus. They want to do a 4-month regimen. So that's what what's the results are based on, is that 4-month regimen. And there are some patients who were going to fail. We just try to keep that number really small.
All right. Looks like we're just about out of time. Thank you so much, Dr. Armitage, for sharing your expertise and answering all of the questions.
I stayed on time. I will be down at the education office to collect my hugs. Thank you.
And then thank you. I want to thank Lauren and Alicia for keeping an eye on the chat box. Thank y'all both so much. Thank you everyone for attending. Just quickly before, I know everybody's starting to get off, but everybody that was in attendance that is on the attendance list will receive an email from me with the evaluation link and the post-test link. You need to complete those in order to get CEs. Those have to be turned in by tomorrow, 5 p.m. But I will be sending everyone an email. Again, thank you all so much.
And one thing before you leave, Rachel Munoz up at the state is piloting the pilot. She is the pilot, of the ship. She is getting it done. So know that we're actually looking at it. And, Rachel is taking a very thoughtful and careful approach to how we're looking at things. So we'll be able to actually give you some guidance, when we get around to being able to roll it out. I have all kind of faith in the people that have been chosen to work on it. And just know that, when we get ready to tell you what we're doing, to get it out there, we're hoping to have you more comfortable with how things are rolling. So it's coming. And there you go, Delphina.
All right. Thank you, everyone. Thank you again.
Hey, Delphina, there's one more question. Something
sorry.
to do with TDCJ, which may be important.
Oh, so I think Rachel answered that in the Q&A. Are you talking about the question from Tiffany Bowens?
Yes. Okay, so it was answered. I just didn't see it.
Yeah. Yeah. Do you want me to go ahead and read the response? It looks like everybody's jumping up. All right. Thank you again, everyone. Take care.